Hello friends, a very good evening to all of you and salam to of my Egypt friends and all the doctors. A very warm welcome who have joined here. Friends, today we are having a very special guest with us, a very dear friend of mine, Dr. Saleem with us in the academic series of the digital webinar what we are conducting powered by Sham Well Women Clinic. So Dr. Saleem is a president of Arab Society of Fetal Medicine and Surgery. Thank you, doctor, for accepting our invitation. Doctor is chief board member of the Neo Cleopatra IVF Center and ICU of Monitor. So thank you so much, doctor, for accepting the invitation and very warm welcome to you. Friends, today the doctor is going to discuss with us a very good topic. So regarding the Adnexal mass. So first, doctor will show us the presentation. Later on, you can ask your queries. Doctor, over to you.
Good evening, ladies and gentlemen, and many thanks for Doctor for this invitation to talk with ultrasound and adnexal mass. Now I will talk about this very interesting topic, adnexal mass, and what role of ultrasound to diagnose adnexal mass. But before I will say some Arabic words. رسمتك جد ولا عش تشاغلت باسمك فانفلت القلب نحوك جريا كخيل السباق فقد فاض بي وبه الاشتياق وحين جلست أمامك مرتبكا أتحسس قولي فقد هرب القول مني لكن كلام عيوني قد ناب عني وقال أحبك تغنيك في داخلي موجة البحر زرقة هذه السماء ولا يستبين بغير ضياك الضياء ولا بسواك يطيب لشعر الغناء فأنت الحقول وأنت المطر وأنت الصبا واخضرار الشجر وأنت ابتداء الطريق وأنت. Most welcome with you again in our talk. Pelvic ultrasonography to visualize the adnexia and uterus is commonly performed in symptomatic and asymptomatic women of reproductive and menopausal age. Although pelvic ultrasound is highly sensitive in detecting adnexal masses, its specificity in detecting malignancy is lower. In addition, the differentiation between functional ovarian masses that will resolve over time and non-functional masses has great implications for patient counseling and management. Other types of adnexal cysts, such as endometrioma, mature cystic teratoma or dermoid cysts, and para-ovarian cysts are also important to diagnose correctly since they may affect patient fertility with significant pelvic disease or put the patient of ovarian torsion. Thus, the correct use of pelvic ultrasonography has become an integral part of the gynecological evaluation and examination. The clinical assessment of the patients undergoing evaluation for adnexal masses of the utmost importance in guiding management, conservative follow-up with timed repeat scans versus surgical intervention. The first clinical parameter to be considered is patient's age. While adnexal cysts are the most common in reproductive age women, likelihood of malignancy in this age group is low, and a large proportion of cysts are of function, tending to resolve over time. On the other hand, in postmenopausal women, the risk of malignancy and their suspicion for malignancy are higher. Other factors to consider when events with adnexial masses are symptoms of pelvic pain, which may point to adnexial torsion, but also may be a point to endometriosis or pelvic inflammatory disease or an acutely hemorrhagic corpus luteum cyst. The second factor also abdominal distension accompanied by gastrointestinal complaints and weight loss, which may arise from an advanced ovarian malignancy. And the third factor is use of contraception, which will affect the likelihood of functional ovarian cyst. In addition, their family history of breast and or ovarian cancer, as well as known carrier state for the breast cancer or two genes, will likely direct the clinical management toward this less conservative approach. The most common adnexial mass is a simple cyst, easily identified on grayscale ultrasound by their unilocular appearance. The lack of cyst wall papillae. Further investigation should be taken the cyst's diameter, since small simple cysts usually less than 2.5 to 3 centimeters are of little clinical importance in reproductive age women. Simple cysts are very common and comprise a wide range of pathologies. The self-limited follicular cysts, which will resolve the open follow-up of several months, to benign persistent cysts of epithelial origin, most commonly serous cystadenoma, to the very rare cases of malignancy. Cases of malignancy in simple cysts are rare in all age groups. However, in those cases where malignancy was diagnosed in a seemingly simple cyst, demographic and clinical risk factors for ovarian cancer were present, such as postmenopausal status and a personal history of breast cancer or ovarian cancer. Moreover, cases of malignancy in simple cysts usually involve large cysts, more than 7.5 centimeters in diameter. In many of these cases where malignancy was diagnosed in a simple cyst, the macroscopic examination of the cyst did reveal nodules in the cyst wall, prompting the suggestion that the cysts were, and that a more detailed preoperative ultrasound examination may have revealed complex features. You see this picture, simple cyst. You see this is unilocular cyst with thin wall fluid. There is no papillae or. This picture was taken by transvaginal ultrasound in a 25-year-old woman. This measuring 64 millimeter by 42 millimeter was seen on transvaginal ultrasound in 25-year-old woman complaining of abdominal pain. She was followed for several months with cyst persistent and therefore microscopy. Only a smooth walled cyst containing clear fluid was seen. Pathology revealed a benign cyst. The second most common adnexial mass is hemorrhagic cyst. The most common type of hemorrhagic cyst occurs from bleeding within a corpus luteum cyst. In reproductive age women, the corpus luteum cysts are functional cysts that open conservative follow-up and are diagnosed in symptomatic women with acute pelvic pain, or asymptomatic or in asymptomatic women. The grayscale ultrasound appearance of an acute hemorrhagic corpus luteum cyst is of cyst with echogenic content, which may appear or heterogeneous. In case of ruptured hemorrhagic corpus luteum cyst, free fluid present in pelvis may be observed. Subsequently, when the clot within the cyst is retracted, the cyst appears as a hypoechogenic cyst with an echogenic structure inside it, representing the blood clot. This echogenic structure typically what happened?
I think your side some net. Yes, yes, it's coming. It's coming. Slide is coming.
Okay.
Yeah,
okay.
yeah. Visible, visible.
Okay, no problem. The cyst appears as a hypoechogenic cyst with an echogenic structure inside it, representing the blood clot. This echogenic structure typically moves with transducer ballotment. Finally, a resolving corpus luteum cyst, a process involving hemolysis. Finally, a resolving corpus luteum cyst, a process involving hemolysis of the clot and formation of fibrin strands, appears as an avascular cyst containing irregular fine lines resembling a cobweb reticular pattern. This reticular pattern may be confused with septations, thus raising suspicion for malignancy. However, the reticular pattern seen in a resolving hemorrhagic corpus luteum cyst is different from the septations of a suspicious cyst in several crucial points. The former contain thin lines which don't extend across the entire cyst diameter, where the later contains thicker lines which extends to opposite cyst wall. The classic ultrasound signs detailed above enable an accurate diagnosis of the hemorrhagic corpus luteum cyst in most cases, since corpus luteum cysts occur only in reproductive age women. The appearance of hemorrhagic cysts in menopausal women cannot be due to a functional cyst and often prompts surgical investigation.
Doctor, sorry to interrupt you. Please make your screen full screen. Full screen. Yeah.
Okay.
Yeah.
Okay.
Yes,
This
perfect.
picture.
Yeah.
Okay. This
Yeah.
picture of
Hmm.
hemorrhagic cyst.
Hmm.
This picture was taken by transabdominal ultrasound in 16 years old adolescent. A hemorrhagic cyst consistent with a corpus luteum cyst diagnosed on transabdominal ultrasound in a 16 years old adolescent who presented with acute abdominal pain. A hypoechogenic cyst with an echogenic structure representing the blood clot is observed. In addition, the delicate cobweb is seen. The third adnexal mass is dermoid cyst or benign cystic teratoma. Benign cystic teratoma, the most common type of germ cell tumor, most often diagnosed in adolescents and reproductive age women, because these cysts contain sebaceous material and sometimes hair. Their appearance on grayscale ultrasound is of hyperechoic mass producing an acoustic shadow. This means gradual attenuation of the sound and obscuring of the structures beyond the cyst. Occasionally, these cysts contain mostly sebaceous fluid seen on ultrasound as a hypoechoic cyst with echogenic wall components, which represent a mixture of hair and more solid sebaceous material. In addition, in those cases where the hair component of the cyst disperses into the cystic fluid, the ultrasound picture is of fine hyperechoic lines called dermoid mesh. When the cyst contains bone or teeth, these may also appear as a solid hyperechoic part of the cyst. Despite the diverse appearance of dermoid cysts on ultrasound, their diagnosis is often straightforward, reaching a sensitivity of 99%. Nevertheless, dermoid cysts are sometimes difficult to differentiate on ultrasound from hemorrhagic cysts and endometrioma. In those cases, CT or MRI may help to reach to an accurate diagnosis. Benign cystic teratoma may harbor malignancy in very rare cases, estimated to occur in 0.17% to 0.3% of cases. These malignancies are almost always diagnosed on histopathology, and as yet there are no known preoperative ultrasound grayscale or Doppler flow features that may confidently suggest these diagnoses. However, from a clinical standpoint, suspicion of malignancy in this setting should arise when a benign cystic teratoma is visualized in peri or postmenopausal patients, and when the diameter of the cyst is larger than 10 centimeters. You see this picture for dermoid cyst or benign cystic teratoma. This picture was taken by transvaginal ultrasound in 7 women. A 90 millimeter dermoid cyst diagnosed on routine transvaginal ultrasound in 70-year-old woman. The cyst contains mostly echoic material and produces visible acoustic shadow with attenuation of the sound beyond the cyst. This is also another picture for benign cystic teratoma. This picture was taken by transabdominal scan in a 9-year-old girl. An enlarged ovary was seen on transabdominal scan in a 9-year-old girl with abdominal pain. The ovary containing 2 cystic areas, one with an echoic structure. In addition, the stroma of the ovary appears edematous and the normal follicular structure is lost. On laparoscopy, torsion of the ovary involving a large dermoid cyst was diagnosed. The next adnexal mass is hydrosalpinx. Hydrosalpinx represents fluid trapped in a distended fallopian tube with distal occlusion and occurs in the setting of previous pelvic inflammatory disease. The appearance on grayscale ultrasound is of tubular and elongated cystic mass with incomplete septations or indentation along its wall, waist sign or cogwheel appearance. In order to fully appreciate the tubular structure of the cyst, the ultrasound probe may be turned by 90-degree angle, and a seemingly simple cyst will appear to be tubular. In the chronic stage, small mural nodules may be noted, resembling beads on string. Those typical patterns are highly suspicious for diagnosis of hydrosalpinx. You see this picture for hydrosalpinx. This picture was taken by transvaginal ultrasound in 28-year-old nulligravida. A tubular hypoechoic mass with indentations along its wall, consistent with a hydrosalpinx, was seen on transvaginal ultrasound in a 28-year-old nulligravida with non-tubal occlusion on hysterosalpingogram. Laparoscopy confirmed these findings along with severe pelvic adhesions. The next adnexal mass is paratubal cyst, also called paraovarian cyst. They appear on grayscale ultrasound as unilocular, thin-walled cysts with smooth margins and anechoic contents. In order to differentiate these cysts from ovarian simple cysts, it is necessary to visualize the ovary simply from the cyst. Cysts grow to a large before their diagnosis, and their side localization, right or left, may be difficult. Very rarely, a borderline or be found in a tubal cyst. Usually, the older reproductive or menopausal age groups. Suspicious ultrasound findings in cases of paratubal cyst malignancies include papillary projections growing from the cyst wall. Papillary wall projections may be seen in cases of benign paratubal neoplasm. Benign paratubals are one of the most common adnexal cysts in adolescents, where they can present with acute pain due to torsion. The next form of mass is endometrioma. Endometrioma means endometriosis inside the ovary. Those chocolate fluid fields represent the involvement of the ovaries in the process of endometriosis. Endometrioma has a typical appearance on grayscale ultrasound as or multi-loculated containing diffuse low-level homogeneous echoes, also known as ground glass appearance. However, it is present about 85% to 9% of surgically confirmed cases, while in the remaining, a non-typical appearance of endometrioma is present with cyst wall projections, thought to represent blood clots, heterogeneous appearance of the internal echoes, or even appearance, possibly in chronic ovarian endometrioma. Thus, a difference with hemorrhagic cysts, or even malignant flu, doesn't increase the diagnostic of grayscale ultrasound endometrioma, since resistance indices are in the normal range, and the color Doppler reveals flow only in the system. This picture was a transvaginal ultrasound in 25-year-old women. This ovarian cyst or endometrioma is 58 by 44 millimeter ovarian cyst, was observed on transvaginal ultrasound in a 25-year-old woman who presented with pelvic pain. The ground glass typical appearance of endometrioma is noticed. Laparoscopy confirmed this diagnosis. The next type of The next type of adnexal mass is tubo-ovarian abscess. Tubo-ovarian abscess results from a severe pelvic inflammatory disease and present a breakdown of structures, ovary and fallopian tube, by infection and inflammation process. The ultrasound appearance of tubo-ovarian abscess is variable and depends on the duration of infection. Over time, as the abscess matures, part of its content may appear cystic. The recognition of cystic areas in tubo abscess is important from a clinical standpoint, since those cases may be due to percutaneous drainage. Otherwise, the tubo-ovarian abscess appearance as a complex cyst with thick wall and seemingly solid areas. At times, an adjacent biopsy observed. The clinical presentations decay to the correct diagnosis of tubo-ovarian abscess. The next adnexal mass is peritoneal inclusion cysts, also called pseudocysts. Commonly occur in the setting of previous pelvic inflammatory disease or advanced stage of endometriosis. The pseudocysts represent a fluid trap and therefore have no actual cyst wall. Thus, the shape of the pseudocyst appears irregular, as it is defined by the surrounding structures and adhesions. Often, the ovary is visualized separately from the cyst, but in close proximity to it. It is clinically important to suspect the presence of pseudocysts in the appropriate clinical setting, since their further surgical intervention is unnecessary. There is no surgical intervention to treat peritoneal inclusion cysts, and may involve, if you want to interfere surgically, you may do injury for pelvic structure due to pelvic adhesive disease. The adnexal mass is adnexal torsion. Torsion occurs mostly in premenarche and reproductive age women and may involve an adnexal cyst, either ovarian or paratubal, or an otherwise normal adnexal, also called the torsional adnexal. In the clinical setting of acute pelvic pain, often accompanied by nausea and vomiting, and the tenderness on abdominal and adnexal palpation, the ultrasound characteristics of adnexal torsion are helping the diagnosis of torsion. Include urgent ovary with peripheral thought to represent the stromal edema. You see this of adnexia. This picture was taken by transabdominal ultrasound scan in an 8-year-old girl with abdominal pain. And urgently with loss of follicular pressure was seen in an 8-year-old girl who presented with pain and vomiting. Laparoscopy confirmed the torsion of the adnexia. Laparoscopy confirmation of the adnexia. The picture is more typical of a longer ischemic process. Often, free pelvic fluid is noted near the adnexia. When an cyst is the cause of torsion, it is easily visualized as well, and its nature may be determined. This means maybe dermoid cyst, tubal cyst, or anti-hemorrhagic cyst. Use of Doppler flow may be misleading in the data of the torsion due to high false negative rate. A torsion adnexia may still be seen as having normal Doppler flow due to the ovaries double blood supply from the ovarian vessels and utero-ovarian vessels. The next thing is identification of malignant masses, and this will take large time, and we can talk application of malignancy and in the next meeting, inshallah. I'm very, very happy this invitation from Dr. Ritu, and most welcome with all colleagues, and many thank you for your attention.
Thank you so much, Doctor,
Thank
for
you,
such a
Dr.
nice
Ritu.
presentation. Yeah, thank you. Pleasure is ours. Thank you for enlightening us, all of us, with your immense knowledge. So, Doctor, there are some questions by my friends. Can I take that questions?
Yes.
Dr. Saleem, there are, yes, huh? So there are some compliments are also there.
Yes.
One, my friend, Dr. Rajeshri has joined from Mumbai, Bombay. She is saying a very good webinar. Other is,
Many thanks for you. I want to see you.
yeah.
I can see you, Dr. Ritu.
No, these are coming on my WhatsApp. These on my WhatsApp. On my WhatsApp they have come. My WhatsApp they had come.
This WhatsApp. Okay. Yes. On WhatsApp. Yes.
Yeah,
Okay,
yeah.
no problem.
There, some have sent on my WhatsApp. The other question is by Dr. Samir Shah. He is writing regarding peritoneal inclusion cyst, which is caused by endometriosis with otherwise normal ovaries. How common?
Uh,
Should I repeat?
Excuse me. Can you send this question on my WhatsApp, as the voice is?
Okay. I'm sending. Okay, I'm
Please
sending.
send
Yes,
question on
sending.
my WhatsApp.
Yes.
I will.
Yeah, yes. And
Yes. Okay. According to the inclusion cyst, a peritoneal inclusion cyst, which is caused by endometriosis with otherwise normal ovaries, how commonly because they cause infertility by hindering fembryal activity. Yes, this can affect the fembryal activity. When we do ovum pickup, we are very near from the inclusion cyst, but we don't interfere with it and leave it without any intervention. Yes, this inclusion cyst can affect fembria, especially endometriosis can do infertility by two ways. The first way is adhesion, pelvic adhesion. The second way is bad oocyte. Okay.
yeah. So thank you
Are there
so
any
much,
questions?
Doctor. No more questions. No more
Many
questions.
thanks. Okay, thanks for you, Dr. Ritu,
There
for
are,
this
yeah,
nice invitation.
there are a lot of appreciations are coming by my friends. Lot of appreciations are coming for your talk. So, doctor, from my
Many
side,
thanks for you and for your friends.
this dark chocolate for you for excellent talk here.
Many thanks for you, my dear. Many thanks for you and for
yeah,
your friends.
yeah. So, yeah, and soon we will organize one another talk with Dr. Saleem on this the diagnosis of the placenta accreta. I will announce the
Yes.
date after discussing. Yes, after
Okay,
discussing the
no
date.
problem. I
Yeah,
am ready.
so nice of
Yes,
you.
I am ready to do anything for you and for your friends.
Thank you so much. Acha, let
Thanks.
me want to know what in the starting the two slides what you told in the Arabic, is it the worship to the god?
This is yes. This this is for poet for love of girls.
Okay,
this,
okay, okay. Oh,
this is
okay.
like
Very nice,
song,
very nice.
right? Egyptian song. Okay.
Okay, very
Many
nice,
Arab
very nice.
people listen for us. So this
Hmm.
for ice break of the lecture.
Okay, okay, very nice. So
Okay,
you are
thank
well.
you.
Once this corona pandemic is over, you are welcome to India. Welcome to Pune. So yeah,
Okay, after finish the Corona, inshallah,
yes,
I will
yeah,
go to India.
yeah. So thank
Okay,
you once
thank you,
again.
Arab.
Yeah. With this, we are
Thank
winding up
you.
today's session. So bye bye to all of friends and namaste. Namaste to all of you. Bye bye. Stay safe, stay healthy.
What? Your voice was lost.
Acha. I'm saying now we are winding off the session. Winding off the session, saying bye bye to everyone. Hmm.
Yeah. Yes. Okay. Many thanks.
Yeah,
Okay.
yeah, yeah. Stay safe, stay healthy. We will meet soon. Yeah.
Okay.
Bye.
Okay. Okay. Thank you.
Bye. Yeah. Good
Bye.
night.
Okay. Bye. Bye.
Yeah. Bye.
Okay.
Yeah.
Okay. Bye.
Yeah.